Real life.
So, good evening, young students and friends, and welcome to this 19th episode of All India Postgraduate Teaching Program, which is a new initiative from ARCIS. I think I forgot to wish you all a happy Diwali. How was the Diwali for you? Well, everyone must have enjoyed it, and now it's time for us to come back and get back to our studies. So, this is a program which we are now coming back to. Today's program, we will be covering the genetics part of it, which is a program which is not very well covered in most of the topics in the very textbooks comprehensively available. So today here we are with the 19th episode of this series, which is a didactic lecture on basics of genetics and gene testing and gene therapy as well, which has been a long question asked in the finals of MS exams. Today's didactic lecture would be presented by Dr. Purna Chandra, who is a VR surgeon and a consultant electrophysiology and clinical geneticist at Narayan Nethralaya, Bangalore. And the second speaker will be Dr. Simaranjan Singh, who is an assistant professor at Advanced Eye Center, PGI, Chandigarh. Our discussants are going to be Dr. Mayank Agrawal, who is director, site genetics research and senior consultant, and also a VR surgeon at Fortis Hospital, Delhi. Dr. Rushikesh Naigaukar, who is an HOD of VR services as well as medical director at Sri Ganpati Nethralaya, Jalna. And Dr. Shrikant Kumar Padik, who is a consultant ophthalmologist, vitreoretinal surgeon, and in fact an ROP surgeon par excellence at famous LV Prasad Eye Institute in Bhubaneswar campus. I'm really thankful to three of them for consenting to be our discussant. Now, without much ado, I would request Dr. Purna to share his screen and begin the talk.
So good evening, everyone. So hope my screen is visible in full screen mode.
No, not no. Now we can see it. Yeah.
Okay, fine. So thank you so much again, Prashant Bhavan sir, Kasturi ma'am, and other ARC members for giving us this opportunity. I know, before I start this topic, once we talk about it, it's a post-graduation talk, and you must be wondering why we should learn about genetics, gene testing, gene therapy. We are more worried about cataract, clearing exam, and all that. But let me tell you, the field of genetics is evolving at a very high pace. Irrespective of the specialty you practice, you will come across a patient who will have some kind of a genetic problem, who will require some kind of an orientation to guide them where they should go, where they should consult, and all that. And sometimes some of your relatives might bring some reports. My so and so is having so and so problem. Please guide us. So at least it's that. So some of you might take up as a VR specialty, and who knows, you maybe in future you will be speaking about these topics. So from that aspect also, it's quite important. And as sir rightly mentioned, sometimes you might get short notes and a long answer also, depending on the format of your question paper, like either DNB or your state. You might get a one long question also. So you need to know about basics of genetics and gene testing. I have toned it to very basics. I pardon my colleagues Shrikant, Mayank, and Simar if it's very basic for you guys. I know you guys are little veterans when it comes to genetics and electrophysiology. Fine. So genetics is the study of heredity in general and of genes in particular. It forms So before we go into the understanding what is genes, genetics, and all that, we need to know this is the central dogma of biology, which all of us would have learned in our 12th in high school also, where DNA replicates on its own and RNA gets synthesized by a process called transcription, which in turn undergoes a process called translation, resulting in functional proteins. So in our DNA, we have two reasons. One is coding and non-coding. The coding is called the exon, and the non-coding region is called the intron. So exons, that means the coding region, which ultimately results in functional proteins, it's only 1 to 2% of the entire genome. The rest, 98%, is a non-coding gene. non-coding part, which we call it as introns. So clear? So this is important. The reason being, so whenever we do a genetic testing, we need to know what type of test we do. In whole genome sequencing, as the name suggests, we sequence the entire genome. That means which includes both exons and the introns, both the coding part and the non-coding part. And the cost involved also is little high, and the time taken is also a little more to generate the report. The second type of testing is the whole exome sequencing, where we end up sequencing all the coding region of the DNA. We exclude the intron, the non-coding. And this is one of the most commonly done test for the whenever you opt for a genetic testing. So in case if you don't know what to order, just order whole exome sequencing. So the cost is little less compared to the whole genome sequencing. The whole genome sequencing, most of the time we do as a part of research project, but for from patient perspective, it may not be of that benefit at this point of time. But of course, there are some reports which are coming. The intronic changes also can influence the exonic and all. For that's for a different discussion altogether. And the third test is the next generation sequencing using a panel of genes, where we, within the exonic region, we will be targeting the specific genes. Okay, for example, we will end up sequencing only those genes which causes retinal dystrophies, or only those genes which are involved in corneal dystrophies, or some of the orbital disorders or syndrome. So cost, definitely it is much lesser compared to the whole exome and the whole genome sequencing. So that's as simple as that. So whenever you get a question, just first write the central dogma of biology, the coding part, non-coding part, what is the role of coding part, non-coding part, and the type of genetic testing what we have. Fine. So before going further, we need to understand the difference between a dystrophy and degeneration, because the whatever the concept of the genes genetic testing, it revolves around the inherited retinal dystrophy, non-inflammatory condition. They will have an early onset. They are bilateral and symmetrical, whereas degeneration are sporadic. So usually have a late onset, unilateral or bilateral. Whenever if it's bilateral, most of the time it will be asymmetrical. The best example is age-related macular degeneration. So, like that's the best example. We don't call age-related macular dystrophy. We call it as age-related macular degeneration, because it doesn't follow Mendelian form of inheritance. Okay, so this is the basic difference between a dystrophy and a degeneration. So fine. So now we need to again understand some of the basic terms like autosomal dominant, recessive, X-linked, and all that. In autosomal dominant, inheritance, the only one copy of the disease allele is necessary for an individual to be susceptible to express the phenotype. For example, if the father is having a defective gene, definitely it will be expressed in the children's also, whoever receives that gene. Whereas in recessive, it requires the two copies of the allele to be defective to cause the disease. As you see in this diagram, the parents are carriers and the normal. The children who receives the defective copy, they express the disease, that both the alleles in this particular, the son is affected. The daughter has received normal copy from the father and one normal copy from the mother. So she is completely normal clinically, and genotypically also she is not a carrier. And some children who receive one good copy from one parent and one bad copy from one another parent, they become carriers. So that's about the autosomal recessive, because this is important, because most of the disorders what we see in ophthalmic, most of them are autosomal recessive disorders. X-linked dominant is just like an autosomal dominant, but the mutation happens in X chromosome, where only one copy of the disease allele on the X chromosome required for an individual to be susceptible for the disease. So the males and females, they equally get affected. Whereas X-linked recessive is slightly different. It is like an autosomal recessive. The why I'm telling it's slightly different, because males will have only one X chromosome, whereas females will have two X chromosome. So because of which, even though it's a recessive disorder, the males will get affected, because we have only one X chromosome. We don't have another X chromosome which can produce a good proteins. So all the females will become carriers. But females also can get affected, the provided the both X chromosomes carry if they have the defective gene, and if it's recessively inherited, then the females also can get affected. Otherwise, most of the time they will be carriers. So whenever we have a recessive disease expressing because of mutation in both the alleles, we call it as
Think we have lost him.
these two terms are important. I'll explain it when I come to the clinical case examples.
Purna, can you go
So
back?
fine. The
Purna,
yes,
we
yes,
missed
sir.
you last
Yes, sir.
last 2 minutes. We missed you.
Oh, is it? Oh, I'm so sorry for that.
In between,
Could you please?
it's being missed. On and off, it is going on.
Yeah, on and off your
Oh.
volume is. So autosomal recessive, you have to come to X-linked from there.
X-linked.
it is
Okay. Am I?
Dominant.
Hope my voice is clear now.
Yeah, better.
Am I audible now?
Yes, yes.
Okay,
Keep your
fine, sir.
video
Fine.
output or input off.
Yes, sir. I have switched off the video. I switched off my video so that the bandwidth will be a little better.
Okay. Yeah, Dr. Purna.
Sir, can you hear me now?
Now we can hear you. Yes.
Yes, I just switched it to maybe a better internet. So hopefully this shouldn't be a problem now. So fine. So yeah. So I think autosomal dominant, I'm extremely sorry for that interference. So again, we understood about autosomal dominant and autosomal recessive. So when it comes to an X-linked disorder, X-linked dominant is also like an autosomal dominant, but this happens in X chromosomes. Okay. So the males and females have the chance of equally getting affected. Whereas in X-linked recessive, there is slight difference as compared to autosomal recessive. Okay. So the reason being, the males will have only one X chromosome, whereas females will have two X chromosomes. So because of which, even if there is a single defective copy, the males will express the disease because we don't have an other X chromosome which can produce a good proteins. Whereas in females, because they have two X chromosomes, if there is a one defective X chromosome, if the other X chromosome is normal, which can produce a good proteins, they may not express the disease and they just become the carriers. Of course, in females also, if they get both the defective genes, they can also manifest the disease. So that is something important when it comes to an X-linked recessive disorder. So coming to the macular dystrophies, it can be autosomal dominant and autosomal recessive. I don't want you people to mug up these things. Just remember some of them are dominant and some of them are recessive. I'll explain it with a case example, which will help you to remember this. This, if you try to, mug it up, definitely will forget it. Okay, so just important one, you remember like Best macular dystrophy and cone dystrophy, autosomal dominant radial Duchenne, North Carolina, and things like that. And other common dystrophies like Stargardt's, autosomal recessive bestrophinopathy, as the name itself suggests, these are all recessive disorders. And there are some dystrophies which affect the peripheral retina, like retinitis pigmentosa, rod cone dystrophy, sclerodermia, and gyrate. So why I'm giving example of retinal dystrophies in genes and genetics? Because as I told in the beginning of my talk, the genetics in ophthalmology, most of 90% of the time, it revolves around the inherited retinal dystrophies. So just let me explain the same with a case example. So this was a 11-year-old male who had blurred vision with a vision of 6/9. So this is the pedigree chart of the proband. So whenever you suspect any genetic disorder, the first step is to make a very good. See this, our proband, the deceased person, we call it as the proband. Proband is the person who first presents to the clinician. He was born out of a consanguineous marriage. That means the parents were related to each other, which is quite common in some parts of the India. Hope I'm audible.
Yes, yes. Please go ahead.
Okay, fine. Sorry, in between I keep checking so that to be very sure. Okay, this is the fundus picture of the same patient. As you can see in the macular region, there are some vitaliform like deposits with an SRF. Once we do the autofluorescence, the vitaliform deposits are seen better. So this is the corresponding OCT where you can see a subretinal fluid and also an associated deposits in the subretinal space. Okay. So we did ERG and EOG in this patient. So I will not go into the details of ERG because that's for a different class. So just in a, what you guys can just follow is whatever that is there in the blue color belongs to the patient. Sorry, the normative data, the black color belongs to the patient. That's all. If you look at the dark adapted responses, it's all normal. Even the light adapted responses are normal. That means the fulfilled ERG in this particular patient is normal. Look at the EOG now. Like electrooculogram is basically we do it to test the function of the retinal pigment epithelium, which has got a dark trough and a bright face peak. Normally there should have been a peak like this, which is absent. That means the electrooculogram is abnormal. So this is very classic of a Best disease, which is a dominant disease. The ERG will be normal, whereas EOG will be abnormal. So the reason being, the Best disease happens because of the defect in a defect in a bestrophin gene, which is supposed to function within the retinal pigment epithelium. Fine. So when we did a genetic testing in this patient, the proband was found to have a heterozygous mutation in BEST1 gene, suggesting autosomal dominant inheritance. I'm introducing a new word called heterozygous homozygous. It's very important to understand these terms because most of the reports, genetics report what you get, you'll often see these kind of terms. So in heterozygous basically means, I told in dominant disease, only one defective allele is enough, other will be normal. So when the one is defective, another is normal, we call it as an heterozygous state. So which usually is the case in dominant disease, whereas in recessive disease, both the alleles will be defective. We call it as homozygous. Okay, so in this case, there is no confusion. We suspected BEST and we got the BEST gene. But the problem was in this family, the father was also found to have same mutation, but he said, I'm normal. I don't have any problem. So then we called so this is the family, this is the proband. So this is the father, the second row. If you see the father's left eye fundus, just in the parafoveolar region, there is a vitelliform deposit and a corresponding OCT change. So the disease can be as subtle like this. So this is a very important example where screening of the family members is very important. Sometimes they may tell they are normal, but they may have some subtle changes. So the other two family members, the mother and the sisters, they were clinically also normal and they also did not have any mutation. So that is something very important. Once you get any genetic report, it doesn't end there. It's the duty of the clinician to correlate the genetic test result with the clinical picture and help the geneticist to understand it in a better way. So just looking at the genetic report in an isolation can never be conclusive. Fine. I'll just go to the second case example. This was a 20-year-old male born out of consanguineous marriage, had a blood vision of 618 and a narrow angles with hypermetropic refraction. So this is the fundus picture. If you can see, the foveal reflex is not seen very clear. The disc and the vessels appear to be normal. If you see along the arcades and beyond that, there is a diffuse yellowish deposits. And when you do it in FFA also, there is some non-specific staining and leak. So don't worry about the FFA change. I'll just show the autofluorescence now. So whatever the deposits which I mentioned in the fundus photograph, this can be better appreciated when you see an autofluorescence. So these are nothing but the vitelliform deposit. If you remember the first case, the vitelliform deposit was limited to the macular region. In this patient, it is extensive everywhere, sparing the macula. And if you look at the OCT of this patient, the first patient, if you remember, it had only subretinal fluid, whereas this OCT, there's both subretinal and also intraretinal fluid. So this is a classic case of autosomal recessive bestrophinopathy. So the first one, what you saw was a dominant BEST. This is a recessive BEST. It's the same gene, but depending on the inheritance pattern, the clinical picture might differ. And it's very important to diagnose these kind of cases because I get a lot of these cases for a second opinion who gets misdiagnosed for a posterior uveitis. And by the time they come to me, they'll be on steroids, antivirals, immunosuppressants and whatnot. Okay, so we did genetic testing in this patient. Before that, we always have to do electrophysiological test. In the recessive test, both EOG and ERG both will be abnormal. Okay, so the proband was identified to have a homozygous mutation in BEST1. This is what I was telling. In the first patient had a heterozygous mutation because it was a dominant disease.
Purna, hello, Dr. Purna.
Parents were heterozygous carriers. So this becomes very important. That means the
Purna,
parents were
please step off this
heterozygous, they were
slide.
not manifesting.
You were
Hello?
muted. You were muted during the explanation of this slide.
Okay. Only this particular slide, no, sir.
Yeah.
Am I audible now?
Yes.
Okay, fine. So when we did genetic testing in this patient had a homozygous mutation in BEST1 gene. Homozygous means both the alleles were defective. In the first case, if you remember, it was an heterozygous where one allele was normal, other allele was defective. The proband's unaffected sibling had a normal genotype. The parents were heterozygous carriers. So this is very important. That means they were carrying one normal copy and one abnormal copy, whereas the son inherited one abnormal copy from each parent. That's the reason he's manifesting the disease in a severe way. Is that fine? So that's about the dominant and the recessive disease, where I took an example of the best disease. Let me go through one more case example where this was a 10-year-old female with a vision of 6 by 60. The fundus photo, if you carefully observe, the disc, the vessels, everything looks fine. In the macula appear, there are little atrophic changes. May not be appreciated very well on the color fundus photo. And after that, we did a pedigree. We got to know that she was a product of consanguineous marriage, and she also had one more sister with similar problem. So look at the corresponding autofluorescence. There is an hypoautofluorescence. So the atrophic changes can be better appreciated when you do an autofluorescence test. And also there are multiple hyperautofluorescent flecks, which are not very obvious on the color fundus photo. So it's very important whenever you suspect a dystrophy, you should do an autofluorescence test. And if you look at the OCT, I know most of you are familiar with the OCT. There is a foveal thinning with outer retinal loss. RP is also atrophied, and choriocapillaries also have started atrophying, resulting in these hyperreflective dots. So this is a classic example of a Stargardt's disease, where there has been atrophic macular changes with multiple flex-like deposits. So we did an ERG in this patient. So as I told, if you look at the dark adapted responses, the blue belongs to the normal, the black belongs to the patient. Definitely there is a delay and also delayed response and also diminished responses. Both the dark adapted and the light adapted responses were affected. You might ask me, sir, it's already diagnosed as Stargardt's. Why do we need to do an ERG? In what way it's going to be useful? So the reason being, the Stargardt can be of three types, and our patient belongs to a type 3 Stargardt's. I will tell you why. In type 1 Stargardt, the fulfilled ERG is normal, in which case the chances of progression are nil. In type 2 Stargardt's, only cones get affected and there will be 20%. As in our patient, the cones and rods both get affected, in which there is 80% chance of progression. So sorry for the spelling mistake. So this is by the Professor Graham Holder had done an observation study for a 20 years follow-up, where this is the conclusion out of his follow-up data. May not always follow this, but most of the time they follow this kind of a pattern. So whenever you do an ERG, in a way you can prognosticate also. When we did a genetic testing, this patient did have a mutation in ABCA4 gene, which is known to cause Stargardt's disease. So this ABCA4 is an interesting gene. I'll tell you why. Because it's characterized by accumulation of a lipofuscin in the RPE cells, what we refer to as A2E bisretinoid. I'll example the same with this cartoon. If you look at this fundus photo corresponding ERG gene function, suppose if this ABCA4 gene is functioning normally, the patient can have a normal appearing fundus. If there is a partially functional ABCA4, you can have a typical Stargardt's like picture. If the ABCA4 function is severely defective, you can have a fundus which shows cone rod dystrophy kind of a phenotype. If there is a severe, like ABCA4 function is totally absent, then the patient can also present like an retinitis pigmentosa like picture also. This is extremely important when you deal with genetic disorder. It's the same gene, but depending on the severity, the phenotype, what phenotype means what we see clinically, the clinical pictures could be different. For example, if the patient comes in this stage, I may falsely label that patient as retinitis pigmentosa. So it's very important we get a genetic testing done so that we can counsel the patient properly. Fine. So that's the reason sometimes Stargardts can have a normal non-specific foveal alteration, or it can have a classic beaten bronze appearance, which is a classic textbook description, and also with flex and all, but may not be the case always. The clinical presentation can vary. So when it comes to I've added this management slide only for this disease for a specific reason. I'll tell you why. So currently there is no treatment. We are starting the gene therapy and all that. I'm sure that Simar is going to cover that aspect in his talk. We have to give a low vision aids, and it's very important to give dark glasses to avoid bright light in Stargardt's patient. The reason being, the more the bright light they get exposed to, the more the visual cycle keeps running, the toxic byproducts keep increasing. So we need to give them a photochromatic glasses. And the same thing happens whenever if we give an vitamin A or any kind of antioxidant supplements to them, we are stimulating the visual cycle, thereby increasing the formation of bisretinoid. So these should be avoided. So I still get a lot of patients of Stargardts who will have prescription for this. Some of
You're muted again. Dr. Purna.
coming to the next case example, this was a 24-year-old newly.
You missed
Hello.
last two sentences.
I said no. Basically, dark. I was telling in Stargardt's group of disorder, the vitamin A and A rate supplement should not be given. The reason being, it will stimulate the visual cycle and the toxic byproducts will increase. So these things should be avoided, because I still keep seeing patients who have this prescription for one of these vitamins and vitamin A and all. That should not be done. So next case is a 25-year-old newly married female who had diminution of vision since childhood. She knew the diagnosis. She knew have retinitis pigmentosa, but she came to us because she was interested in planning for a family, and central vision was quite okay for her. This is the fundus picture. I think most of you are familiar with this kind of picture. This is a classic case of retinitis pigmentosa where you can see waxy discolor. The fovea appears relatively healthy, and there are multiple bone spicule-like pigmentation along with gross arteriolar attenuation. So clear, and this is the corresponding OCT. If you can see, the ellipsoid zone is present only in the foveola. That's the reason these patients will have tunnel vision. The retina in the parafoveal region, especially the outer retina, is degenerated. So this is the pedigree of this patient. The pedigree though looks beautiful, but it's not actually. Look at here. This is our patient who was born out of a consanguineous marriage. She in turn got married consanguineously to his maternal uncle, to this person. So which is quite common in this Indian scenarios. And she also had one more brother who was affected with a similar disorder. So the first thing is to screen the family members. We thought of, we should examine the brother, because, like once they tell my brother also has some problem, even if they're using glasses, people tell he has some eye issues. So it's very important. You should call them to the clinic and examine. So that was the first step. So this was the affected brother. He had night vision problem. Central vision was quite okay. But if you look at the fundus, again, he had an features suggestive of retinitis pigmentosa, though maybe an earlier or a milder form compared to the sister because he's younger. So, and there was an aborted coloboma, you can ignore this. But if you look at the periphery, definitely there is a bone spicule-like pigmentation suggestive of retinitis pigmentosa. Now, coming to the genetic test result, the patient had a mutation in gene called CNGB1, which is known to cause retinitis pigmentosa. So, what does this mean to a clinician or a patient? So when we screened the brother and the husband, in a homozygous state, But the problem here was husband, since he was related to her, he was carrying the same gene in heterozygous state. Since he was heterozygous with other allele being normal, he was not expressing the disease and he was asymptomatic. So here we have a situation where it's a mother is homozygous and carrying the two mutated genes, and father is normal and carrying one defective gene. There is a 75% chance that the fetus will get affected. So in these case of scenario, they need extensive counseling to go for an, so either amniotic fluid sampling or CVS, chorionic villus biopsy and all things like that. CVS we don't do because there are more results of limb defects and all that. But amniocentesis needs to be done in the first trimester to look whether the fetus is affected or not. The other option could be they can go for an embryo selection also. So that's where again the genetic testing and the counseling becomes important to guide the patients to plan their family. So I'll just show this last set of clinical example. If you look at these two patients, the first patient and the second, the fundus appeared normal. Both patients had blurred vision. The first patient, in addition to blurred vision, also had photophobia. So if you look at the autofluorescence, the first patient had a very subtle changes to the fovea, and OCT showed a small cavitation in the subfoveolar region. But look at the ERG. The ERG, the dark adapted responses are completely normal. If you look at the light adapted responses here, the black line which belongs to the patient, it's flat. It is almost undetectable. Okay, so we'll try and understand why that's happening. Coming to the second patient, if you look at the autofluorescence, there was more obvious atrophic foveal changes, which is again confirmed when we did an OCT. Let's do an ERG. Look at the ERG. The dark adapted responses are completely normal and light adapted responses are also normal. So in the first patient, the defective is less, but the ERG is telling a completely different story. In the second patient has more atrophy, but ERG is telling this disease is just localized to the fovea and rest of the retina is normal. The reason being, the first patient is a case of achromatopsia caused by a mutation in a gene called GUCY2D, which is a form of stationary cone dystrophy. So this being stationary, though the cone dysfunction is very severe, this patient is not going to progress. So we need to counsel them because most of the time these patients are concerned that they are going to go blind. You need to tell them you're definitely not going to go blind. You will have some difficulty in distance vision and the near vision, but you need to use photochromatic.
Yeah, Dr. Purna. Hello. I think Dr. Purna, we have lost you.
On and off, it is getting muted.
Yeah. Dr. Purna, I will call him just.
Yeah. Or we can go ahead with a second. In any case.
So perhaps while Purna joins, we could maybe take on some discussion points. So just moving further into the talk, perhaps one of the things where, just to add that very often when the report comes out of the patients, the genetic testing, the mutations, and so the testing reports are often labeled as whether the report is pathogenic or it is likely pathogenic or something known as a variation of uncertain significance. And essentially, perhaps just to add on to that, very often the patient's variations that are seen in the sequencing could be just polymorphisms, for example, or something which is maybe causing a phenotypic change or may not be. So when it's absolutely described, we would say that this gene and mutation has been described and it's a pathogenic mutation. But there are certain times when we might see that there is a change in the sequencing that we're seeing, but it's not really corresponding to a phenotypic change very often. So it could be a variation of uncertain significance.
I
So,
think till Dr. Purna joins, can we have Dr. Simar? Can we go ahead with your presentation?
Yeah,
Yeah.
sure, sir. If you say so.
Please do
Yeah.
share.
Simar uploads his presentation. Can I have a point here, Dr. Prashant?
Yeah, please, go ahead, Doctor.
Yeah, we are discussing about the genetics, but the thing is that before jumping into any genetic testing, we have to clinically ascertain that this patient is having some genetic diseases, or what Dr. Punna also shows. So most of the cases like wet RMD, dry RMD, and these are misdiagnosed. And even after the genetic report comes, disclosing the results has to be with utmost care, because these are medical legal issues also can rise if any abnormal reporting, or if we cannot like kind of interpret the result appropriately. So one has to be extremely careful while interpreting these results, like what Dr. Mayank also told. And also kindly explain to the patients about the risk of passing to the next generation, and prenatal testing if the patient is planning for any future pregnancy. So just I wanted to give one example. I had a case of a lady who was diagnosed to have ABCA4 mutation, that is Stargardt disease. And although she knew about the disease, she got married to a like normal patient, and her parents didn't disclose about the disease to the husband or his family. So what happened? So after like her first child was a missed abortion, and in the second term, and somehow the husband came to know about the disease. So in such cases, when we went ahead with chorionic venous sampling or other testing, amniotic fluid sampling, the fetus was turned out to be ABCA4 positive. So those cases are extremely, because this is not like mortal. So ABCA4 mutation can lead you certain degree of morbidity, but it is not mortality. So on an ethical ground, I don't know whether this is to be aborted or not. So genetic testing comes with some pinch of salt. So that is the importance of genetic testing in retinal dystrophies.
Dr. Simar, you can upload your presentation. Till then, Mayank, you can add some more Rishikesh.
Yeah, so just to add to what the others, Mayank and Dr. Pali has already mentioned. So going for full exome analysis is sometimes can lead to this kind of misdiagnosis. So it would be a great thing to do if we can just correlate it clinically and advise specific tests. And if it turns out to be negative, and if you have a high index of suspicion, then it is always better to go for a full exome analysis. This can also save some cost for the patients.
So I think we will go ahead, for want of time. We will go ahead with the second presentation, and it is by Assistant Professor Simar Ranjan Singh from PGI Chandigarh, and he will be speaking on gene therapy. Over to you, Dr. Simar.
Thank you so much, sir. Am I audible now and my screen is visible?
Yes, well.
Thank you so much. And thank you to ARC and Dr. Prashant for this opportunity. So I think we had a very illustrative talk from Dr. Purna discussing about the importance of genes and the genetic testing that is coming up. And I think most of that interest has spun up over the last decade because of gene therapy coming into these diseases, and having some hope that yes, we can treat these diseases. So that has kind of developed our interest into genetic testing and understanding more about these diseases. So I'll just give a broad overview of what are the approaches for gene therapy for a postgraduate level. So inherited retinal diseases are a group of phenotypically diverse disorders with varied genetic mutations. And as you can see from this illustration, there are so many genes involved, and these are just the genes. There are thousands of variants of these genes further, which can further complicate the genetic heterogeneity. And thus it makes it difficult for us to characterize them properly. And there were limited options for treatment in the past and at present also, but there is big hope in the future. So given this genetic heterogeneity, genetic testing has become important to characterize a disease specifically, because phenotypically a lot of them might look similar. And just grossly, how we try to classify these inherited retinal diseases based on whether the whole of the retina is involved or only the macular area is involved, whether they are progressive or they are stationary. We saw a few examples. This is just an example of that. So what are the options when we have, once we are thinking about vision restoration in these patients? So there is a cell death. We know there is a RP loss, there is a photoreceptor loss, something going on in the outer retina that is a problem. So some of the options that are available to us is, one is cell replacement. So that has been partly successful for the, as far as the RP is concerned, where cell lines have been grown, both human cell lines as well as animal cell lines, and they've tried to transplant these cells into the human retina and try and restore some function. So that is cell replacement. Gene therapy is more directly targeting the cause, where there is a problem, you try and correct that gene over there and provide a solution to the problem. Optogenetics is something of recent interest, where you accept that some cells are a problem, but you try and kind of utilize the other cells which are normal and try and give them similar functions as what those cells have. So if the photoreceptors are not functioning, you try the bipolar cells and the ganglion cells, give them some chromophils and see whether they can detect light and transmit some light and give some vision to the patient. So that is optogenetics. And then obviously prostheses, which are still being developed. They were developed and used and then taken off the market, where you kind of bypass the retina on a whole and you connect directly with the camera, directly the light that you are seeing with the functioning optic nerve, and try and get the signal back to the occipital cortex. So today what I'm going to concentrate on is this aspect, that is the gene therapy aspect of this options for vision restoration. Retina has long been considered kind of an ideal target for gene therapy, because it's a very enclosed, immune privileged site protected by the blood retina barrier. So anything foreign that you are going to introduce into the body is going to react to it. So wherever there's reacting cells, the lymphocytes are lesser, those might be better targets for gene therapy, as the response may be slower in those. It has a small size, limited amount of cells, so you know what you are going to target over there, the retina. There are established surgical procedures to reach the target site, so that is a good thing. And we can relatively monitor the retina because we can directly see it. We have tools to cross-section it with the OCT. We have autofluorescence. We have electrophysiology to get the responses. So it's a very promising site for gene therapy to work. So prior to 1990, retina did not generate much interest, but post 1990, there has been a lot of development to identify vectors for retinal gene therapy delivery. There was kind of a setback in 99 for the whole of the gene therapy, when because of the retroviral vectors getting integrated into the host tissue, there was death of a patient and multiple patients developing leukemia. So that kind of set back gene therapy research by a decade. But then again in the 2000s, the research again began, and the turning point came for retinal gene therapy in 2017, when Luxturna, as we all know, voretigene nevirobac, for RPE65 biallelic mutation got approval from the US FDA and subsequently other agencies. And that was kind of the turning point. And now currently there are more than 1,000 active clinical trials for gene therapy, out of which more than 30 are for ocular diseases, the retinal diseases in particular. So this development is kind of a very long process, because you have to first identify the genes which maybe you may target. You have to identify the vectors. You have to develop animal models for it. You have to do preclinical testing in them, do in vitro testing, and then come on to clinical testing. First, this phase 1, phase 2, the safety testing, and then see whether there is any efficacy of that or not. So it's a very long process that we are talking about. So let's just try and understand what we are trying to do with gene therapy. So basically, we have a part of the DNA that is not functioning well. We just heard about how the DNA and the RNA, the transcriptional and the translation kind of works. So the DNA is the part that is going to be defective, where you are not going to get a good RNA coming out of it. The transcription product is at fault, and that RNA is subsequently going to make either no protein or a wrong protein, a mutant protein. So if you have a no protein, that is the case in most of our autosomal recessive disorders, you would want to kind of replace that missing protein by replacing the gene in the DNA. And that is something we call as a gene augmentation. So that is one approach to this. And that is what Luxturna also uses, where you kind of try and replace the defective gene with a normal copy. The viral vector takes that gene into the cells, inserts that normal copy into the cells and without inserting itself, and then kind of hope that the normal function will kind of return. But if you have a mutant protein where the protein that is being formed is wrong and that is giving a wrong kind of input, there is a gain of function mutation, then you would need something like a gene editing. And also for genes that are very large in size, which are difficult to package within the viral vectors, you need therapies that can edit the gene in vivo instead of replacing them with a completely normal copy and correct the base pair mutation that is there. Or you could kind of have silencing of the wrongly formed protein. This is very common in autosomal dominant disorders, where you have a wrong protein that is being formed from one of the strands, and that is kind of giving the wrong signal. So you can try and silence that with the help of antisense RNAs, which kind of try and block the expression of the wrong RNA that is being formed. And also some interest has been recently developed into gene modification, where you try to, instead of directly affecting the gene, you upstream or downstream, you're trying to modify the whole pathway so that you can get the final product that you require. So that is gene modification. And these are just the comparative table of the 4 approaches that are there. And all of them have some form of trials that are going on within ophthalmology also. Between augmentation, silencing, editing, and modifying, the first 3 that you see are kind of very gene specific. So if you have one particular, you need to have separate vectors for each of the genes. And gene modification is kind of something that is being developed where you could target a group of disorders, say something which is affecting the rod function or the cone function as a whole, rather than having a very gene specific therapy, which could be on paper kind of economical than the other therapies. So the target delivery is very important. Once you have detected the gene, you have developed a patch for it, you want to take that to the target cells. So there are 2 kind of vectors that are available which carry these tissues, this DNA into the cells that are, they can be viral vectors or non-viral vectors. Viral vectors are the one that are most commonly used because they have they have tissue specific tropisms. So they will go to the specific tissue. They have improved specificity, so they will reach the specific tissue only, and they have a robust transduction, means the effectiveness of the therapy is more. But then there is a problem with them also because a virus being involved, they may induce an inflammatory response. And once there is an inflammatory response, those cells can subsequently die over time and their effect can be reduced. There is risk of insertional mutagenesis and oncogenesis as happened, as I told you, in 99. So especially with the retroviruses, this risk is very high. The adeno-associated viruses are the ones that are most commonly used because they are relatively stable and can carry the gene, required gene into the cells. The problem with them is that we have a limited payload size. So the very large genes cannot be carried with the help of the viral vector. So we have a limit to the size of the gene that can be used with them, that can be corrected with them. Non-viral vectors, where you can you put in the genetic material directly, use liposomes or inorganic material are also available, though they have lesser specificity and are more and are lesser stable than the viral vectors. So they have a more problem with delivery. And then obviously you need to get the product as close as possible to your target cells. So for inherited retinal diseases, you would want, because most of the times your photoreceptors and your RPE is going to be affected. So you would want to be as close to that as possible. So subretinal gene therapy has been the most effective and the most commonly used approach now. But then because it is so invasive, that is kind of an off-putting factor. So suprachoroidal and intravitreal approaches are also being tried to try and get a little less invasive, but try and have the same advantages as a subretinal gene therapy. So this is just not an exhaustive summary of something, just to know what all diseases are being currently targeted with gene therapy. These are trials, and you can see the phase of the trial that they are currently in. So achromatopsia is one thing that is being targeted, and this is something that is soon of the CNGB3 gene soon going to enter into phase 3 trials. Age-related macular degeneration is also of interest because of the number of patients that are present, geographic atrophy, as well as diabetic macular edema. So these are some of the non-dystrophies that are being trying to be targeted, so that we can modify the expression of VEGF and kind of see if we can modify the course of the disease. Then Leber's congenital amaurosis, we already have one therapy, and there are multiple others, including one using gene editing with CRISPR, that is for the CEP290 gene, and that is also advanced, kind of in an advanced stage of testing in the clinical trials. So these are just clinical trials, not the preclinical trials that are ongoing. Along with, you have therapies for retinitis pigmentosa, both syndromic as well as non-syndromic, as well as X-linked retinitis pigmentosa, which are again in phase 3 and are in an advanced stage of testing, where you are trying to see the efficacy of the vectors rather than their safety. X-linked retinoschisis to prevent progression. There are therapies that are being developed. So this is something that you should know about. Stargardt's disease, as Dr. Poorna was talking about, even Narayana Nethralaya is trying to indigenously develop a vector for Stargardt's disease, because we have a lot of burden of this disease. But because it's a large gene, it's a little difficult for gene therapy. But there are therapies that are being tried to develop for Stargardt's disease as well. So there are multiple challenges in gene therapy also. Most important is the identification of the disease, the causing genes. So when we order genetic testing with a good clinical suspicion, we still have a rate of about, I still have a rate of about 80% positivity. So there are still about 20-30% of the genes that we don't know about that are causing these genetic diseases. And there are many more diseases that we don't know have a genetic predisposition yet. So that is important. Once is identifying the genes, the development of the animal models, and then the vector selection and development to deliver the gene therapy is another important aspect. The route of delivery, as we talked about, the method of delivery is going to be important. Immunogenicity and toxicity is something that is lately being talked about, even with the Luxturna therapy, where you are seeing some progressive atrophic changes in the long term in these patients. So because it's something external that we are introducing into the eye, the behavior is always going to be unpredictable. So we are learning on the way as we are doing that. And obviously the cost of development as well as the cost to the patient, which is exorbitantly high right now. And that is one of the challenges that it will need to come down in the future for this therapy to be viable. So I think I have some case examples, which because need for early diagnosis is something which is very important, because we know that some of these diseases, for gene therapy to work, we need these cells over there. Even for achromatopsia, as we discussed, it is a non-progressive disorder functionally, but anatomically it is kind of progressive because the retina kind of atrophies as the time goes on. So you need to kind of detect these early, so that you have some functional cells over there where you can introduce the gene therapy and restore the function. If everything is perfect, your gene therapy is not going to work, because gene therapy is targeting the cells that are already left. You can't introduce new cells in gene therapy. So that is important, that you need early diagnosis. So that is where our role comes in as clinicians, to kind of detect these disorders early. So I think I'm going to skip this in the interest of time, the case examples, and I'm just going to go to my future direction slide. That gene therapy is no longer the future. It's here and we need it and we need to be ready for it. Developing our own database to know our genetic makeup is vital at this stage. And early diagnosis will become increasingly important as therapy will be dependent on the stage of the disease that we are going to treat. And cost-effective approaches are required to make gene therapy within the reach of the common man. Thank you so much.
Thank you, Dr. Simar, for carrying out this wonderful talk. In spite of you being in Nepal for Nepal VRSI, you had the time, you had to spare time and get into the hotel and do it for us. We are really thankful. So meanwhile, I had a chat with Dr. Purna. He's ready now with a new network. Can we complete in next 10 minutes, Dr. Purna?
Yes, sir. Hopefully, sir.
Yeah.
Yes, sir. Hopefully, I'm extremely sorry again. I just inquired. I think entire locality there is an issue. So
No issues, no issues. You just share the screen and let's begin immediately.
yes, sir. So till may I know, sir, till what slide was it visible so that I can continue from there, like in case if you...
We were at yeah, exactly. We were here itself.
Okay, this slide was completed, right? Or I just want, you want me to repeat this?
No, this was done.
Okay.
Yeah.
So basically in this slide, what I was trying to explain is, hello, can you hear me, sir?
Yes, yes. You go ahead now.
Yeah. So basically in this slide, what I was trying to explain was like if you take any of these tests in isolation, either the clinical photograph, OCT, or autofluorescence and ERG, we cannot come to a conclusion. So as Dr. Simar was also mentioning in his talk, it's our clinician's responsibility to connect all the dots so that you can give a patient. So, like diagnosing dystrophy is not about just telling there is no treatment. We need to tell patients about what are the limitations, what's the possible prognosis, what are the possible career option, what they can choose. So that's where the role of genetic testing comes. Genetic testing is not about the family planning and all. To an extent, you can prognosticate also. And the most important thing, the moment you diagnose a patient with retinal dystrophies, like for example, if you say retinitis pigmentosa, what patient does is he will just go to the Google and type retinitis pigmentosa and they will end up reading things which may not be relevant to his condition. Whereas if you do a genetic testing and if you give them the report, he can just go and specifically search for that thing. In a way, it will help them also to keep a track of the research. So, in conclusion, I would like to say genetic test helps to understand the gene responsible for the condition. So, once you know the cause, it's easy to find out how far the research related to that gene has progressed and also whether or not gene therapy is available for that particular gene. And literature also guides the patient and clinician to understand the prognosis, as I was explaining with the achromatopsia and Stargardt cases, in a better way. And families, as I explained in the RP, this thing definitely they can plan for a healthy child with the help of genetic testing. And awareness is very less in country like India. It's very important. We as a clinician, irrespective of whether you're a retina person, cornea, a general ophthalmologist, or a postgraduate, you need to create awareness among the people. So this is the usual workflow, what you need if you want to do a genetic testing and all that. First, the clinician has to examine the patient and to label that is a disease which is due to a genetic defect. Then the patient and the attenders, that means the close relative with the consent of the patient, need to undergo an extensive genetic counseling, which is very important, because genetic testing, it comes at a cost. So patients should not have an unusual expectation that the moment we do genetic testing, we are going to get the treatment. So it's very important we draw a pedigree and do a counseling, then draw the blood and subject them for a genetic testing. And once genetic test report comes, our clinician job is to correlate everything as I showed in the previous example. The cycle continues. Sometimes all the genetic tests may not be a conclusive. You may get sometimes variants of unknown significance and all that, where we need to dig out the literature, do a deep clinical phenotype and help in the diagnosis. So this is my last slide. Like with the advent of better advances in genetic testing tools, genetic counseling has become of primary importance. It helps the patient to make better choices, better understand the prognosis, and to know what future holds for them. Thank you so much.
Thank you, Dr. Purna. Finally, we could complete your talk. Now I invite the discussants, Dr. Mayank, Dr. Rishikesh, and Dr. Padi to go ahead with the discussion over the same topic. You can unshare the screen for a while, Purna.
Sir?
You can unshare the screen. Yeah.
Yes, I
thank you.
unshared it. Unshared.
Thank you. So, Dr. Padi, your comments on it.
Yeah, very lucid speak by Simar. So I see the approach to the retinal dystrophies in a two-way. So first is it is mutation specific, also called as genetic approaches. So one of them is gene therapy. That is what Simar just explained and very clearly. A second is that mutation independent, or also called as gene agonistic approaches, or these are also called as non-genetic approaches. So these approaches include basically retinal cell replacement, for example, retinal pigment epithelium replacement or photoreceptor replacement. Second is retinal prosthesis. So we know about Argus implant, and though results are not that much, the expected results are that much clinically applicable to the general population. However, there are some hope. And one last is optogenetics. So the brilliant paper by Sahel et al. Last year, where they published about the optogenetics. So just one case, imagine just one case of optogenetics where they showed good results is like path breaking for the world. So the disease is evolving, and we are at the right time for gene therapy and even for gene agonistic approaches.
Can you highlight a little bit about CRISPR? Because sometimes when we hear the conferences, people speak about CRISPR in terms of gene therapy. So can you just highlight a little bit about it?
So
Yeah,
CRISPR,
Mayank is
ma'am,
the right
kind of,
person.
Yeah. So CRISPR, broadly speaking, is the bacterial immune response against the viruses, and it essentially consists of a Cas9 enzyme, and that enzyme, along with a guide RNA, is able to locate particular areas of the DNA. So once the guide RNA along with the enzyme, they bind to the DNA, they tend to cause a double-stranded break in the DNA. And that's what the classic CRISPR is. Now, one of the limitations found at that time is that once the DNA is broken, there may be potentially insertion deletion mutations which are there, and that may further cause effects that we do not desire. So therefore, CRISPR was further modified so as to use something known as a deactivated Cas9 enzyme along with a domain which has a deaminase domain. So basically, it is very effective against point mutations, specifically transition point mutations, wherein an adenine base can be deaminated into a guanine and a cytosine to thymidine. So these are called adenine and cytosine base editors. And the whole technique is called a base editing. And further, the whole technique was modified into something known as CRISPR prime editing, wherein a reverse transcriptase domain was further added to the Cas9 enzyme. So essentially, the Cas9 identifies the part of the DNA, then there is reverse transcriptase, and then there is some amount of DNA which helps first identify, then cause nick in the DNA, and then synthesize the desired wild type of the gene, which we want. So one of the major challenges with CRISPR, of course, it's very potent and it won the Nobel Prize in 2020, has been that it can have off-target effects where we don't want them to be. And sometimes there may be a challenge with the editing efficacy, that all the cells may not show a DNA edit. So typically, an editing efficacy of about 30% cells is shown to show some amount of phenotypic changes as well. Now, further, there has been modification into something known as RNA editing. So the whole CRISPR machinery can be utilized to just edit the RNA so that you don't make genomic DNA changes. So that's broadly been it. Edit 101 using the CEP290 gene and Edit 102 for USH2A gene have been some of the leading ones. CEP290 now has actually been stopped by Editas. But yeah, all of these modifications keep changing as will keep evolving as time goes.
Purna or Dr. Seema, do you have anything schematic, whatever Dr. Mayank had told for the sake of understanding of a postgraduate? The CRISPR, the versions like this, any of you have any slide which we can share to
I think Mayank has a slide. Mayank he himself has a slide of the thematic thing.
which
I
can
think if you have,
student understand what exactly the difference between the various things you spoke about?
Sure.
basically Mayank's, yeah, you can just share it. He has a slide.
While I pull it out,
Yeah.
yeah, perhaps you could continue with the
Sure.
discussion while I pull it out.
You
So
can add-
basically, in the future of gene therapy, I know like it's going to be the common. I know it's little complex. I'm not sure we can discuss everything in this form. So in the future, it's going to be combination therapy. So it's nothing one specific thing is going to work. So like genes can act at the molecular level and can start producing the correct protein. So that doesn't mean that these proteins will reach the target cell and they'll do the expected function. Again, maybe there could be a role of optogenetics also. And if the cells are totally lost, there's no point in either trying our CRISPR-Cas9 or a gene therapy. We need to survive a surviving cell. In those cases, cell replacement can come to a rescue. So that's how the future is going to be. Like, for example, ABCA4 is one.
I
think is again muted. Simar,
Yeah. I agree with what Purna has just now said, that we probably need to look for a combination therapy like a stem cell therapy in addition to the gene therapy, because one of the important challenges in it is, apart from the vectors and other issues which Dr. Simar has already discussed, is the inflammation after the injection has been done, and that itself can nullify the effect of the transduction which has been done there. So as he has already rightly said, that yes, we can definitely look for a combination therapy.
So Mayank, you are ready? Can you just elaborate for the sake of our postgraduates?
Yes, absolutely. So this, the maroon color thing is a depiction of, for example, the Cas9 enzyme. And the yellow is, for example, the guide RNA. So these two things can be essentially engineered in the lab. And especially the yellow part, the guide RNA, can potentially be designed so that you targeted the mutation or the desired area of DNA to bind to it. So once the complex binds, it causes a double-stranded break in the DNA. And then thereafter, we could have the inherent DNA repair mechanism to cause something known as a homologous directed repair, homology directed repair, or a non-homologous end joining. And like I was sharing, that sometimes these do cause insertion deletion mutations whilst the DNA is being repaired. And therefore, there has been a move towards developing the CRISPR-based editing, wherein you have a catalytically deactivated Cas9 enzyme. So that is, it does not break the DNA, but along with that, it does have a deaminase domain. So essentially what that does is that it is going to deaminate cytosine to uracil, which is read as thymidine, or it deaminates an adenine to inosine, which is read as guanine. The other further mechanism or the change has been the prime editing. To make it simple, essentially, there is a reverse transcriptase domain along with it, something known as a prime editing guide RNA. So once the Cas9 enzyme binds to the DNA, it causes just one strand of the DNA to break, a nickase activity. And along with that, the reverse transcriptase then uses the prime editing guide RNA to sequence or the desired type of DNA that we want. So this can effectively treat all kinds of mutations, insertion, deletion mutations, or transition, transversion mutations, making it very potent. That said, the challenges are that it can also cause a lot of off-target effects. So therefore, there has been a movement towards now CRISPR RNA editing, wherein you are able to edit at the level of mRNA instead of the DNA to mitigate deleterious genomic DNA changes. Right. I think that broadly summarizes all of it.
Thank you very much. One more thing I would like to know, like you have been discussing about optogenetics. Like, can you just explain it to us very like in a very simple way, because I could hear in your discussion, many of you were speaking about optogenetics, like it may be one form of treatment coming up very soon. So can we just briefly make it very simple for us?
Dr. Simar.
Yeah, so optogenetics, as I told ma'am, so we are trying to target the cells which are preserved, which are normal. So our photoreceptors and RP is kind of affected. So we are trying to target the inner retinal cells, the retinal ganglion cells, the bipolar cells, and trying to give them some function that the photoreceptors have. So we try and incorporate some chromophore pigments into them so that they can detect light and transduce some light to the occipital cortex, and that may help. So there are multiple types in that, but that is the basic gross idea, that the cells which are not affected in your pathway, you try and utilize them to gain some visual benefit out of that.
Can it be in sometime used for treatment of retinoblastoma? Like anything, has it come something like this? Like,
I'm not sure about that one.
okay.
No, there has been, I mean, attempts to, like the correct this second hit, what usually it happens, but it has to be at the gene level. It has to be through the kind of gene editing. So the other downward pathway approach, like I'm not sure about the CRISPR, but other like optogenetics may not work here. So it has to be at the gene level. So there are some experiments going on. Animal models have been trying. I think I should be able to possible the way things are going, should be able to do it in the future. Yeah.
So
It's
can I
all about handling the second hit. That's all that you need to make that sure that that second hit doesn't happen. So just do a genetic testing, but confirm whether the RB gene is there or not. Once you confirm it, just target it. So that's all. Especially treating a sibling would be maybe more meaningful than targeting a patient who already has a disease, maybe something like that.
So if you have about 18-20 therapies, as you said, means for various genetic disorders, retinal disorders, where do you see as where we are going to see the light at a very short period in few of these diseases?
Yes, gene therapy, of course, gene therapy.
Yeah, but
Of course.
how early in which
think this
particular set of diseases? Means you said it's a broad spectrum.
This
Many
is going to be
I think
kind
Dr.
of the
Simar
next
has already
revolution
briefed it
after
one of the slide. I
anti-VEGFs.
think he can.
once more, just for the
Kind of
second.
like we are using anti-VEGF so
Mm.
We missed you.
yeah.
I think Simar, we missed you. You said something. Dr. Padhi, can you add to it?
Yeah. So just I want to add is that maybe 10 years back, this gene therapy was in the laboratory. 5 years back, it came to the bedside, and now it is in the bedside. So the final challenge is to make it public. So that is the thing. The most, like, if I can say, the constant factor is the cost. Luxturna is like it's very, very costly. So I don't know. We have to make some government policies because we cannot give that visual outcome. You cannot measure the visual outcome based on the gene therapy treatment cost. So maybe for someone who is completely blind, hand perception, hand motion, or some light perception can be beneficial for them. But we cannot measure them quantitatively in terms of like vision or anything. So we have to formulate guidelines. So it is now, you can say, at the bedside of the patients, and very soon it is going to be public.
I think you put a very important point. I think so, even with Luxturna that is available. So I think we should not go out with the idea that gene therapy is there, the patient is going to be sick. So that's not the idea. So the recovery that we are talking about are very subtle, because these are patients who are absolutely not able to see. We are giving them mobility. So those are the kind of terms we are talking about, and not kind of a very radical recovery as of now.
Mayank, can you sum up?
Yeah, absolutely. I concur with Simar, and perhaps just to add to that, that in that perceived trial for Luxturna, we did see that there is just marginal perhaps change in the visual acuity, but mostly it's the nighttime sensitivity, the dark time sensitivity, which perhaps improves for the patients seen on the MLMT and FST testing. So yeah, this is a very to sum up, sir. This is of course a very exciting area. It's very rapidly evolving, and I think a lot of indigenous work happening as well. So and especially given the fact that in India we are also likely to see very different mutations as compared to what's reported in the West, and that's what we're seeing. So the need for developing indigenous therapies would be more and more as well. Um, let's hope for the very best in the future.
So we have an exciting world of genetic therapy coming future, I think. Yeah, Rishikesh, you were adding.
I just wanted to add that I think, as Mayank has rightly said, that a lot of patients still cannot afford to undergo the genetic testing. And it's time that we should have our own Indian panels of these genetic mutations, which can be specific for kind of Indian patients, where it would be cost effective for them as well as less time consuming. And if that I think should be the first step and the way forward as far as this is concerned in the Indian scenario.
Great. Anyone has to add further? Simar, Purna, Mayank?
Yeah, just one point. Can I add?
Please,
Yeah.
please.
Just one point for all the postgraduates. Just remember that Luxturna is only for RP65 mediated liver congenital amaurosis. It is not for any other LCA. So this is one kind of gene therapy where one mutation is targeted. So this might come as any Viva question or even short notes.
Yeah, that was very important basically because it's not a miracle drug for all the labor amaurosis. It's only for that particular variant, which you should remember, postgraduates. I think we had a very exciting discussion and in fact a great learning for us also, because though in spite of being a clinicians and retinologist, we were quite shy from this particular field. Thank you, Dr. Purna and Dr. Simar, for making us more, knowledgeable and understand and how we can utilize it for the best of our patient. We very well understand that it is not necessarily about the genetic therapy and genetic testing that it might necessarily benefit the patient per se, but prevention in the next generation and identification and counseling might be very important, and that will definitely make the life of that particular family more palatable for that coming years. So, and gene therapy, we will be seeing lot many things with, I think Narayan Netralaya also is doing a lot of work. PGI Chandigarh is also doing. I think Mayank is spearheading that particular thing in a private practice in a Delhi. Padhi is also involved and Dr. Rishikesh is also involved. So with so many young brains working in our country, we are sure we will be having a panels which can help us out in detecting the diseases specific for our country. So we have already overshot the discussion time, but it was very exciting discussion and we couldn't stop the discussion in time. So students, I hope it was a great learning for you. Now it's time for us to say bye-bye from our end till we meet on the next Thursday. Okay, and my sincere most thanks to Dr. Purna and Dr. Simar, especially Simar, because he had to steal out his time from the busy conference at Nepal. And of course, to my dear friends, Dr. Rishikesh, Dr. Padhi, and Dr. Mayank for sparing their valuable time at this hour when a match is an important semi-final match is going on and everyone is sparing their time away from that TV sets. I'm really thankful for sparing those time, wonderful time for my students. Thank you, Kasturi Madam. As usual, you are always with us for this postgraduate program. So once more, thank you to one and all. And let's catch up students again on the following Thursday at 8 p.m. for further discussion on a postgraduate round.